kéo qua chơi trải nhá. Đấy ảnh đẹp cứ giữ là thế nào.
chỉnh cái này là chỉnh đó cho chị. Được kìa, bắt đầu.
I apologize to change the topic here. Some words word format will be broken. However, I hope you understand what I mean. Yes, my topic is biocredit orthodontics, especially for the young patients facing treatments. About the concrete treatment strategy for the class 2 and class 3 skeletal problem cases, you will learn from Dr. Leticia Corridor in this afternoon. Then, what I want to share with you is a kind of clinical tip and clinical know-how for your daily practice in the young patient treatments. Yes, Sun is back from 2019, the rest coursework of biocreative structures. I currently work in the Gyeonggi University Department of Orthodontics as a head professor. And also, I currently work for the director of the Biocreative Orthodontic Strategy Center in Gyeonggi University Dental Hospital. Yes, and this is my kinds of family members. The Professor Kim Kim, current department chair of St. Louis University, and Dr. Gerald Mason, and Yustaka Arabzer, and Ralph Bergs. So many friends of mine helped me to become a big eyes in this field. From this January until 2026 December, my university government has a contract with the Harbin City, the second hospital. It is National Hospital, to operate the new biocreative orthodontic strategy center for the Chinese patients. Every month I visited this hospital. Every month for 2 whole days I treat young patients and I educate the doctors. I share information about the research. Yes, I'm proud of telling you I had a great experience to organize the 2 whole years training program about BOS with you. Many of the attendants or many of the BOS members of Vietnam attended here. I feel so thanks for your attending and continuing your BOS way. Also, currently I am working as an honorary department head of National Hospital of Odontostomatology in Ho Chi Minh City till next year. Then, what is the Biocreate Orthodontic Strategy Center now? A few days ago, my residents took a recording like this. Digital, manual, so many kinds of cutting-edge information and knowledge is combined for the target approach, for the great treatment for the patients. We have 8 miniature. This is only for the biocreative orthodontic strategy. In the first floor of my hospital, huge orthodontic clinic we have. Yes, as you can see, US is not the British Orthodontic Society. However, the abbreviation is the same. Biocreative means the creations. Creation is related with the stomatogenetic systems. Please consider this. Our stomatogenetic system is composed as nerve, muscle, bone, and teeth. They function with harmony. They make this possible: respiration, mastication, deglutition, and speech. You are the honorable, you are the proud of orthodontist. You are the proud of becoming dentist. Many people, many orthodontists thinks about normal function of the stomatogenetic system. They move the tooth, they move the bone, they move the soft tissue. However, the orthodontist and dentist, we control the sign of a cell. Therefore, you all are proud of becoming the orthodontist positions for your patients. This patient, she did not receive any other treatment, orthodontic treatment. However, in her 83 years old conditions, quite harmonious, quite good periodontal condition. When we do orthodontic treatment for the patients, our goal should be like this. The BOS is for the physiologically stable occlusion. The BOS is for the functional harmony. And finally, BOS pursues the aesthetics and happiness of the patients and parents. The BOS has the categories like this. From the young patient or quite young patients after delivery, the infant till elderly patients, we do diagnosis, we do treatments. In them, what is the infant BOS? The Professor Heran Chu is a world famous the craniofacial deformity related orthodontist, and she is quite strong and non-surgical approach for the airway problem infant. Quite happy when we see her biography. She is proud of the announcing. She is related with biocreative orthodontic strategy, and especially her clinical focus is nanometer, cleft lip and palate, and biocreative nano. This is Professor Heran Chu, and the right side is Professor Jung Chang, the founder of the BOS. He founded the BOS in 1979. Yes, I said hello to Dr. Trump. Yeah. With the BOS, we grew, we improved the Vietnamese orthodontist, the knowledge and advances are amazing. So I have a big responsibility to continue to share my cutting-edge knowledge, share my experience and information with you. Infant BOS. This patient has Robin syndrome. Instead of performing this direction osteogenesis under general anesthesia, my group, we applied the innovative the slip oral airway plates, and we molded the airway and we controlled the tongue. Yes, tongue is quite deeply with the mandibular jaw growth. Actively, we use the tool, we use appliance like this. This is 5 weeks before SOAP and 7 months The Professor Chu's group used 6 months with SOAP only, and the growth was like this. And wait, the same situations. When the mandible grows actively, we found the patient's normal growth tendency of the mandible. This is infant BOS. However, today, you wanna listen, you wanna get some clinical information for your patients. That's why you are here. Therefore, I will share information about BPO, primary and mixed. In the primary and mixed dentitions, some issues, timing for intervention, growth potential, prediction is possible, or vertical growth pattern is good or not, quite confused. However, the young patients, the growth is great, the factors for controlling the treatment quality. Primary and mixed dentition BOA try to become the friendly approach derived from our senior ideas. The proper first system with target approach. And finally, we want to emphasize you, let's keep pediatric orthodontics simple and safe. Nowadays, for the patient treatment related research, it's quite difficult to get the control group information. Therefore, we published many research articles in the 1984, 1991, 2000, 2000, early 2000. We published many scientific articles. PO. However, in 2020, only 2 articles is published. Please check out the BOS checklist. This is good for both of the young patients and old patients. The BPO and BOS, we use the 5 essential checklists. First, diagnosis. Second, what is the target decision? Third, what is the treatment tool for these patients? Treatment. 4, target to smoke or soft tissue movement. And finally, we do detailing and finishing as usual. For the young patient treatments, teeth, bone, tongue, airway, and especially growth potential is quite important for the young patient's treatment. Maybe during my presentation, I'll use the term TE or tongue elevator, bioexercise or bioex or pre-order. Please do not worry about this. I will explain more concretely during my presentation. This is the definition of BOS, the BPO. What is the biocreative pediatric orthodontics? BPO actively uses its growth diagnostic treatments of primary and mixed patients with full and target approach. I will use this. I will explain 3 different situations. The BPO first situation. How about this? Oh my gosh. Maybe I edited something. However, it was not. Well, yeah. BPO space management. This is from the Dr. Yusaka Araujo's the textbook. BPO space management. We have. Sorry. BPO space management, the managing oral habit, space maintaining, space regaining, space creation need the stage of the first stage or second stage occlusive development. This is primary dentition and early mixed dentition. I saw in the exhibition booth the huge Invisalign booth. Yes, Invisalign is the world famous and world #1 clear aligner appliance, the companies, the brand name. And in Korea, the Invisalign first for the young patient treatments is quite a kind of major trend nowadays because the general dentist and pediatric dentist try to use as many Invisalign first as possible to the patients. Mainly, this is for the late mixed or early permanent dentition. However, please think again, when you order the Invisalign first for your every patient's cases, then you will give the huge money to the company, and you should receive, you should order, request the payments from the patients, huge monies. The BOS sometimes consider the clear aligner the advantage in young patient treatments. However, through my presentation, you can find, wow, BOS is a quite cost-effective approach for the young patient treatments. One of my favorite friends, Dr. Calvin Wayne Changta, sent the email message to me about the concept, about the philosophy of BOS. The BOS, the Chinese language is like this, Sun Qizhen, and let nature take its course, less is more. Yes, this is the BOS way. However, he agreed to me about the different Chinese word. Too much interference does not improve, but kill it on the contrary. Yes, in the natural growing stage of the patient, please consider the less is more or let nature take its truth. We have 10 key principles. The first presentation of Dr. Owner was about airway issues. For the young patient treatments, we have four key principles. The take principles. Take principles means tripod and airway is important, and keep an eye on growth, and E equal treatment effect equal good mechanics and patients and parents cooperation. And most importantly, I want to introduce you the tripod principle. It's like the tripod of a camera. If the tripod is not harmonious, then camera is pulled out. This tripod relationship is important for the young patient's treatments. How about these patients? This is not the patients. My alumni is the kids. Every year, they take X-ray, they take impression, and we check them. From 6 years to 13 years, once the upper anteriors and lower anteriors, and upper first molar and lower first molar erupted and occluded well, then rest of the teeth followed their way. This is the formed tripod and formed facial growth. However, what happened in the tripod collapse cases? This class 2 retrogradating mandible cases in 1983, we used some, my older colleagues used the functional bionator to protract the mandible. However, when they achieved the tripod, when they achieved the over relationship, but there is no tripod because there is no slides, no figures in here. Unfortunately, because of tripod collapse, she showed the asymmetry in the dentitions. This is the current situations when the entries erupted. The central incisor erupted well, but lateral incisor eruption speed was quite different. Therefore, once the right lateral incisor, upper right lateral incisor, the erupted well, but no left lateral incisor, the totally performed. Therefore, finally, tripod was collapsed, and high canine and midline deviation we could find. This is a tripod collapse, and deformed facial growth can be expected. Then how can we evaluate a collapsed tripod condition simply? Firstly, facial exam. We do check up the harmony of facial and dental midline. Excuse me, could you copy my original file again and give me one assistant? I will give you my record computer. Because some important photos are deleted. Yes? In the facial exam, when we do check up the tripod condition, harmony of facial and dental midline, lip, occlusal plane canting, or chin deviation were not, we check up. In the intraoral examination, we checked up the overjet and overbite relationship, and we checked up the premature contact, and we checked up the kinds of occlusal plane conditions. And in the panorama examination, we usually checked up the missed permanent teeth or not, arch length discrepancy or not, eruption path of tooth, especially for the central incisor, canine, and first molars. This is the panoramic evaluations. Therefore, for the facial exam, for the IO exam, for the panoramic exam, this is the checklist. Especially for the intraoral examination, I already informed you the occlusal plane canting or not, premature contact or not, the positive overjet and overbite or not, we checked out. Then how about these patients? These 6 years male patients showed the collapsed tripod. The family visited the center. The baby teeth between the upper front teeth did not pour out, and the midline or occlusal relationship became not good. Yes, this is a Majordan's case. Let's check out the facial exam. Facial and dental midline condition is not good. However, lip occlusal plane canting problem, no problem. The chin deviation is no problem. How is the intraoral examination? The symmetric eruption, the upper central incisor, lower central incisor, prominent premature contact, the positive overjet overbite relationship. In these patients, this is not good. The premature contact was shown. Therefore, tripod collapse was due to this reason. And in the panoramic exam, you can see there was no missed permanent teeth, and arch length discrepancy we can find, and eruption path of tooth relatively bad because right canine and left canine angulation is relatively not good. Therefore, our target decision is mainly for the things. Wait for a minute. The occlusion collapse. Therefore, it's very important to correct the collapsed tripod conditions. This is what happened to the normal growth. Because of the different speed of lateral incisors, the final occlusion, final the midline, final the arch-raise discrepancy condition was not good. Therefore, tripod collapse means deformed the facial growth. To evaluate this is the facial exam. As I told you, we should firstly check up the harmony of facial and dental midline, and lip and occlusal plane canting or chin deviation or not. And this is intraoral exam. We check up the symmetry eruption or not. We check up premature contact or not. We check up the positive overjet and overbite or not. And in the panoramic radiogram, it's quite important to check up the panoramic at the same time. The different angulation of canine should be considered. Therefore, let's summarize the checkup list. This is a facial exam, intraoral exam, and panoramic exam. Okay, these cases I will explain again. In cases of major dens, you can find the facial exam, the problem. Yes, harmony of facial and dental midline? No. How's the intraoral examination? Symmetric eruption? No. Premature contact? Yes. Positive overjet and overbite? Maybe not, because there's one shallow overjet and overbite. In the panoramic radiogram, what happened? Yes, there is no congenitally missed permanent test. However, arch length discrepancy, yes, and the central incisor and canine, especially the canine and light central incisor angulation, it's not good. Eruption path is not good. Therefore, the target was this kind of the major dens. The major dens, we started the treatment only extract major dens and waited. This is 3 months after extraction of major dens. Yes, natural growth and natural root formation and movements of the root we could find. And then we can check out without any other appliance after extraction of major dens, we could find midline improvements he showed. However, we do something for the patients as a treatment tool. Then please watch this, the panoramic radiogram for the CT. This patient's root formation is not finished. Therefore, instead of applying the tooth movement appliances, such as aligner or such as the fixed appliances or such as the removable appliance with the active spring directly to the tooth, we only control the rotation, and we maintain the space like this. Rotation, but we did not prohibit the natural eruption. Therefore, this was good for the patient's upper dentition treatment, and for the lower, the patient showed relatively hyperdivergent pattern, relatively. Therefore, to prevent from longer face, we decided to apply the tongue elevator. Tongue elevator does not prohibit natural jaw growth because it used only one occlusal rest for the permanent molars. Therefore, upper one appliance is removable active plate with the anterior biplane, and lower tongue elevator. This is what happened during the patient treatments. Tongue elevator, and we asked the patient and parents to perform some simple MFT work. This is what we achieved from this treatment. Then the summary of this case, we waited for 3 months after the removal of major dents, and the patient visits 16 times every 2.25 months for one visit, and maxillary tools, fully tight space management appliances with anterior biplane and lower tongue elevator. That's all. Let's keep pediatric orthodontics simple and safe and cost-effective. This is what I want to emphasize you. Yeah, in the Dr. Araujo's the textbook, the use of lower the lingual holding appliance, lingual arch is the safest way to preserve and control mandibular space. However, in the cases of the moderate or the severe, the arch-length discrepancies, what we should do? These tools, they suggested only 0 to minor the arch-length discrepancy. New concepts, new theory I suggested in the BPO. For the BPO space management, please watch this. This is castle in the sky animations. The castle floats like the boat in the sky, floating, primary, teeth, anchoring theory. Please remember this. What happened to this ankylosed teeth or implants? The ankylosed teeth is not float in the bone. Therefore, they prohibit the natural growth of the jaw. That's what happened to these young patients. But on the contrary to ankylosed tooth, primary tooth, if you use this as anchoring, primary tooth does not prohibit jaw growth, either the bone growth. And in some points, permanent teeth, dentition's growth, eruption. This is the FDA concept. We applied the bonded lingual arch, no banded lingual arch, and we controlled with interproximal reproximation, and we waited. The bonded lingual arch connected the primary molars, moved anteriorly and posteriorly, and they does not prohibited the other bone growth. Therefore, we could use the leeway space as effective as possible. Okay, and then we removed it. at the primary test. How about these patients? Yes, lingually tipped, erupted test. What will you do? Clear liner or bracket? What will you do? We should do something for the patients and parents. If we inform them, oh, only waited for some month, then the patients and the parents visit another dental clinics. We should control, we should manage this condition because the patients, the kids, have the painful because of tongue tears. Therefore, we applied bilingual action, bonded time, and we waited. These kinds of U-rooms, sometimes we can activate. The tipping movement we can do. For the lingual arch or for the bio-TPA bonded time, I recommend you to use the Nokoyama company's universal bond kit as a bonding agent. Only the mixed of two different liquid and mixed, and you can apply the bonding agent and only dry with the air. Right there, and then you apply any kinds of the bonding agents. This is 6 months after bilingual arch, 11 months, and 14 months. Please check out. We continuously did proximal cutting to the cuspid areas. This is before and 19 months of BLA. Yes, what we should do? I strongly recommend you to apply the BPO bilingual arch. How about upper? The one central incisor erupted already, but due to some, I don't know the reason, the opposite side, the central incisor did not erupt well. Then you will wait for a long time. No. Once the tripod started to collapse, then central incisor moved to the often midline areas. Therefore, if we do consider, if we use FTA concept in BPO, then what we should do? Yes, bonded type TPA, but in addition to conventional TPA, we do solder. The brass wire or any other light, round stainless steel wire. Only guide, only weight. This is all the things I did for the patient. Please watch this. Anterior crowding patients, however you look, oh, she's quite harmonious facial face. What do you do? Watch this. Please do the target decision. This patient now eruption stage, midline off tendency, arch length discrepancy, but please check out the angulation of both the central incisor became not good. This is the target. We should use growing potential. We should use eruption path. We should use space management tool for these patients. Target is like this. The eruption path of whole erupting permanent entries were bad. Then you think, these patients, I will use blah 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 line first the space regaining. No, we have growth potential to use for these patients. Therefore, let's check out one more thing. And this patient already erupted the lower first molars. Ovo eruption now started. Therefore, we should maintain or control the vertical dimension of already erupted first molar lower, and we should wait till upper first molar erupted naturally. This is what I chose for the treatment 2. Only one. 0.9 millimeter in diameter stainless steel wire connected 0.7 millimeter in diameter brass wire connector. Soldered. That's all. Mesh 10. Tommy Ward first and then apply. Treatment tool selection FTA we applied. Therefore, no more midline deviation. What happened? For the lower heavy tongue prenum, we should correct heavy tongue prenum, low tongue posture, we should correct. We applied tongue elevator, and we prefer to using interproximal reapproximation kits. This is currently used in my center. I will introduce 2 systems. This kind of soul system. This is good for the patients, the young patients who feel a little bit, the fear about the high-speed handpiece or things like that. Okay, lower arch length discrepancy was solved by tongue elevator and space management with interproximal reapproximation. 6 weeks, what happened? We applied only upper bio TPA bonded type with guide wire and waited. What happened further? Over 1 year, we did not apply any other appliance to the upper dentition. Firstly, we applied one bio TPA till 13 months. And we cutting, reapproximation, no pain, the patient. And once the letter inside the liver, then we cut the guide wire. Yes, this is what we achieved. Arch length increased because of growth potential of this patient. This patient, 6 years old female patient, she has amazing growth potential. Then we can use growth potential, floating tooth encouraging, and arch length discrepancy correction using interproximal reapproximation. TPA, tongue elevator, and after that time, pre-ortho with bioexercise. This is only what we use for the patients. Cost-effective treatment tool. For the poor patients, you can apply this treatment with low price, but treatment effect is amazing. This is what we achieved using IoTK, tongue elevator, sometimes pre-ortho, and exercise. This is what we achieved. And now, after we achieved the permanent dentition, we asked the patients, now the second phase treatment we will start because of your lower second molar space regaining. But before that time, please watch this. What's the result of angulation of tooth? I did not anything to move the tooth, only we managed the space. And now, we decided to apply shortly the clear liner, not many stages, because only space regaining. We can do not many stages. And she started the treatments. This is what we do. From start to finishing, whole stage aligner, no. Once we get most achievable result, then sometimes we can use a bracket, sometimes we can use a aligner shortly. This is a biocorrective. AAO, the definition of dental facial orthodontics, means the guidance of dental, jaw, and facial development. Dental facial orthopedics. In addition to this AAO definition, viewers, especially BPO, pursue the target approach, pursue TMJ friendly orthodontics. We try to not to apply heavy pulse face mask in the young patients. Primary dentition and only mixed dentition, we do not do. And differential diagnosis for arch length discrepancy. There is a bad crowding, there is a good crowding. If we see some crowding and if we try to align the anteriors, then lateral incisor can be observed, the root. That's why I mentioned the importance of good crowding. We should differentially diagnose the good crowding. I will show you the next topic. What we will do for these patients. In cases of hyperdivergence and collapsed tripod, the first part was about the space management. The second part is a little bit skeletal problem. These patients, hyperdivergence, class 2, growing patients, long face, and you can see the narrow airway. Yes, he is a mouth breather. We waited for the 1 year to check up. The FMA is 32.1 degrees, not accurate. AMB is 6 degrees. What we will do? What's the target? He is in the groin. He is in the groin. Then what we will do select for the maxilla? The 4 years, the 5 years patients, this patient showed relatively normal growth of maxilla, SNA in the normal range, and normal eruption of dentition, and normal the anterior axis, even though the permanent dentition was not erupted well. Therefore, upper, no appliances. Please remember this patient. This patient is only 5 years old patient. Therefore, we promised him, we will not do apply any other appliance in the upper. No worry. Instead of that, for the mandible, you should help us. We should prevent from the clockwise mandibular rotation and over eruption of the lower right first molar should be prohibited or prevented. Therefore, to correct the low tongue posture and this patient has heavy tongue frenum, we decided to apply the tongue elevator. I want to emphasize again, in the young patients, so craniofacial deformity, so frenum deformity, then sometimes we do cut the frenum. However, most of the patients in my centers, we do bio-exercise with the tongue elevator to lengthen, to activate the tongue frenum. In the diagnosis and the target decision, please check up the definition again. Orofacial myofunctional disorder. This means inappropriate muscle function, not harmonious muscle function. Incorrect habit affects the harmony of the tongue, harmony of the lip, harmony of jaw, harmony of facial growth. Therefore, to correct this kind of OMD, amazing doctors recommended us to use OFMFT, MFT, myofunctional therapy. Yes, this uses the functional matrix theory and growth potential. This patient has low tongue posture and hypoactive, the frenum not good. This is my university's OMFT program. We decreased the conventional, regular OFMFT procedure. However, it's too hard to continue. It's too hard to continue. Instead of OFMFT with patient will and parents the pushing, we used the tongue elevator. The first article was published to JCO, this 2002. This is composed of legible, reservate, occlusive rest, sometimes radiable or lock. Tongue elevators action mechanism is like this. We raise the tongue. Raise the tongue means apply the force by tongue weight toward tongue tangent to the first molars. Space management, inhibition of posterior eruption we do. The first bio exercise in mid-1980s is like that. Patients were apply the tongue elevator and we do use the patient use the thumb. However, thumb should not feel the pressure. The patient should maintain their jaw position and swallow. This is the origin of our bio exercise. This is bio exercise. Next time, I hope to share more concrete information. We do apply the key soft tissue training, lip and tongue training with the tongue elevator. Already, we achieved the treatment result, and you can find DPJO 2022 issues. Tongue posture became scientifically, statistically significantly changing. Therefore, for these patients, we decided to use tongue elevator. The patients did bio exercise. And for these patients, another option is use the high-speed handpiece. High-speed handpiece and cutting the cuspid, visual area cuspid, and then we do swipe, we apply the kind of fluoride approach. This is the treatment change, 6 months and 4 years. Till 6 months, we did not anything except for flying, the tongue elevator and bio exercise. The patients were like this. Please watch this. So many calculus. Even though the patients try to brush this area, calculus, then please appreciate on his trial and endeavor. The doctors should do, wow, you did a great job, guys. You were alive. Wow, you did a good job. This is what he did. This is 4 years facial changing with only tongue elevator and bio exercise. What he achieved. Please watch this. This is superimposition. And on the contrary to mandibular growth, please check out the mandibular molars eruption. This difference was due to by tongue elevator in bio exercise. Please watch it. The tongue posture changes. Through the tongue elevator application and training, the patient's tongue height became increased. Amazing. The influence of MFT is good. According to canine Gibson, it will change. Therefore, after tongue elevator application, to increase or to mold the maxillary more, we applied the preortho system. The reason I use this system, cost effective. Only 9 different sizes, 3 different category class, and 9, totally 9 the kinds we can use. Therefore, quite cost effective. Therefore, as an active retainer, I use this. In the preortho group, sometimes emphasize that this preortho has skeletal effects. However, in the scientific evidence, the presentation or the post presentation, I saw this. after the pre-order application, opposite relationship was changed. But I'm not sure this is the skeletal effect or not. However, as a retainer, it's quite good for use. How about this patient? These 3 years female patients. Firstly, we applied tongue elevator to correct class 3 anterior crossbite and low tongue posture in large tongue condition, and then we applied class 3 corrector with 100 gram per side force, 60 gram per side to 200 gram total force. The class 3 force we applied, this is a 5 years changing. Skeletal effect, environmental control made this possible. And then what we will do? This is 3 years and 5 years later we achieved this effect. As a retainer, for the whole 5 years, we only used tongue elevator and bioexercise we did, and clear corrector 3. Previously it was called as horseshoe, flat horseshoe. This is a facial changing. This is a facial changing. And now, what we do, instead of applying the class 3 corrector, clear corrector, we now started to use by your exercise with the tongue elevator during the sleeping and for 15 minutes and only over 1 hour per daytime, we apply the pre-order. This is for the widening, for the molding the maxillary areas. Patient true right there for the muscle exercise. It's so good. Very simple, that's all. Therefore, Bioexercise 2024, I do not use pre-order for the active skeletal changes. It's a supplementary. But after the skeletal change we achieved as a retainer, tongue elevator and bioexercise, and daytime about 1 hour more pre-order. That's all. Last session, how long I have? I will try to my best there. These patients were simple or difficult. Please watch it. Asymmetry patient. Too many asymmetry patients visit your clinic. How about this? This patient, hyperdivergent pattern, 4 years female patients, class 3 malocclusion tendency. However, more important point is that severe asymmetry you can see. Occlusion catching. 4 years. Then what will you do for this patient? Only wait till growth check ended and orthodontic growth surgery you do? She is quite young enough to be improved the patient harmony. This collapsed tripod can be cured if we do control the environment, if we do control the growth potential, if we do select exact treatment tool. These patients showed some muscle problem. The left side, the cheek muscle was quite abundant, and the rest muscle, you can see the difference in length. What happened to this patient? Right side chin muscle was generously weak compared to left muscle. This is the related with muscle issues. Yes, the Dr. Kondo, the muscle wins, showed this kind of treatment changes. However, we checked out, target is inappropriate muscle harmony and occlusion, canting, and dental problem. Then we should select exact treatment tool. All the time I emphasize today's presentation, I will show you the cost-effective approach. Weak side, strong side muscle different tooth movement needed, different jaw growth needed, what we will do. In my best friends, in my favorite teacher, Dr. Araujo and Dr. Peter Bouchang, his textbook showed us clinical stage of occlusion developed for these cases. The class 3 correction where this kind of correction needed, the stage like this. Class 2 or class 3 malocclusion situation, we should consider what is the problem. Because there was some Jalo, right? Please help me. Okay. For the treatment tool selections, when you check up the function of line, the removable and fixed, the tooth bone, teeth bone, rigid, hybrid, flexible, all the time as a skeletal corrector, you think the activator, bionator, Twimble or Prunkel. In them, Prunkel is a great training appliance. We should consider in this muscle disorder patients the functional matrix theory. Orthopedic treatment, we should focus more about functional matrix. This is Prunkel truth. But I told you already, this patient showed class 3 hyperdiabetic patients and lower entries already regularly kicked. Prunkel 2 showed more skeletal in nature with better control in the vertical dimension. Training tool, vertical dimension control is good. And please watch this. Lower the lipid made it possible to correct naturally the lower kicked entries. How's the Prunkel 3? These patients, the Prunkel 3 made it possible the growth modification and mandibular positions. But these patients, class 3 hyperdiabetic, but different sheep muscle activity, then we should not use one design of this Prunkel. Then we should modify the design. This is the modified design. This is the modified design. Modified Prunkel. On the right side, weak chin muscle areas. We train the chin muscle. We stretch the chin muscle with a quite large cheek shield, buccal shield. And left area, small cheek shield, buccal shield, and lower for the nature inclination change of the lower incisor, we did apply the lipid in the lower. In the left side, there is a legend block. And right side, there is no block here. Natural eruption is accepted. This is what the patient used. Patient used this modified frontal appliance. And this is the treatment change. 5 months modified frontal appliance, 9 months modified frontal appliance, and what we achieved. What we achieved. Now we are gathering the data. Final case. I applied again for my delayed presentation. I was quite embarrassed. This case is class 3 malocclusion, skeletal problem. It's a simple one. Please watch this. Different style asymmetry. The first case showed us the definite difference in chin muscle activity. However, this patient did not show definite difference of chin muscle activity. Midline deviation, lingually tipped anterior, skeletal class 3, and habeton frenum. Do you know whether this patient's skeletal or dental symmetry? Please watch this. This patient has a different right and left the mandibular body. This is the tip. This is the patient's video format. I have the video format was not extracted. The patient when they open the mouth like this, usually patient showed the improvement of deviated mandible like this. Then we try to correct with transverse control where mandibular position changing. However, in this patient, the patient started to deviate like this, but maximum opening the same. Therefore, we found this patient is skeletal problem, facial asymmetry. Sorry. Okay. I have to see you again. Sorry. Okay. It's good. My presentation is quite really like amateur. Quite sorry. This is a treatment analysis for the patient diagnosis. We use only PA cephalometric analysis. Sometimes we use a community. OSIMI TRY, my department developed this. And in the community we use the article. In them, we checked the OSIMI TRY. This patient showed the translation dominant type. The mandibular body moved like this. Therefore, usually these patients, the treatment is quite difficult to achieve. Already the mandible growth was like this. But we decided to apply the different approach because this patient did not show quite definite difference in right and left side muscle activity. Now, for this patient treatments, we applied the orthopedic treatments using ClearCorrect 3. The ClearCorrect 3 is used at the upper and lower portion appliances and light force flat-ray appliances. Therefore, for these patients, we applied different force of light elastics. We started two treatments. As you can see, upper, the patient showed narrow, constricted maxilla. Therefore, we applied horseshoe expander design for the slow expander. Every 1 term per week, 0.2 millimeter per week, we activate. About a year, we found the gradual change of the overjet and overbite and transverse dimensions. For these patients, right side, the 100 to 120 grams, left side, about 80 grams difference. And from that time to that time, you can see additional change of like this using these kinds of bio exercise with the tongue elevator and pre-order. And what happened to this patient showed the improvements of midline tendencies. And last month, I checked up the data, the patients. Now, we do not use ClearCorrect. We only use the pre-order and tongue elevator combination for the active controlling the retention period. Before the treatments, the patient showed right side 3.7 millimeter translation of mental areas. What happened to this patient? About a year later, the patient showed the change of the midline or translation tendency. This is 3 years of BPO. Patients, the treatment change was like this. We are still gathering data, we are still controlling the patient's muscle conditions also. Clear corrector with the expanded screw, we used it. And then pre-ortho and tongue elevator bioexercise as an active retention protocol. That's all. That's all what we did. Okay, the first conclusion is that in the space problem patients pick up the tripod collapse checklist again and select the treatment tool so well. For this patient, 6 years male patients, for the 3 years, 2.5 years, we used one clear expander and one clear corrector tool. That means clear expander, one clear corrector tool, and then lower lingual arch. That's all. For the space problem patients, use clinical and panoramic examinations to check for tripod condition. Second, utilize the 3 steps of tripod checklist. 3. Actively use primary tests instead of permanent tests for space measurements. And I want to emphasize FTA concept. For the myofunctional therapy or myofunctional problem patients, innovative simple MFT means tongue elevator. You can fabricate by yourself and take action with MFT and applies it. This use growth potential. This use skeletal effect. This use environmental control effect. Conclusion 2. We are gathering the data. I started to using Clearwater for last 4 years, 4 to 5 years. However, this is for the first time I share my information because I did not find the active skeletal effect of Clearwater. Therefore, in the POS, I use space maintainer or molding appliance, training appliances. For the lower tongue elevator, as a training tool, we are developing the 3D printed tongue elevator nowadays. This is my last conclusion. This patient has a problem like this. So many congenitally missed problems. However, to us, this eruption tooth is quite precious. We used only these 3 appliances. Yes, for these patients, I used the clear light. Because of her, she is in the long distance, she is quite cooperative. This is what we achieved. Tongue elevator, bioscrew, clear liner sometimes, and then now we finished with some temporary dentures. I will share more information. I will share more information in the next year, in March. Hope you enjoy the concrete cases again. Both biocreative and orthodontics are ready. I want to apologize again. My presentation, I prepared a lot. However, I really hope you enjoyed my presentation and hope you start BPO for your patients. Thank you.
คือวิ่งหลักอายก็บอกวิ่งต้องอายการมั่นอยู่ที่เดียบานผมยังคือไม่อยู่บานขอบคุณ